Zoll has pushed the boundaries of what is possible for 35 years. In the tradition of company co-founder Paul Zoll, a Lasker award-winning physician and a pioneer in pacing and defibrillation. In addition to his seminal research, Dr. Zoll had a reputation for dedication and careful attention to his patients. His legacy lives on at Zoll.
Thank you very much. I'm going to show a few movies, and seeing what happened to Gavin, I've decided to use my own computer. But it's really a pleasure. This is a topic that is actually very near and dear to my heart because I am one. I'm an interventional cardiologist, and I'd like to show you some interesting aspects today of resuscitating patients in the cath lab. I do have relevant financial disclosures here. I consult for both companies that produce the mechanical devices that I'll speak of today. I have no interest in stock. I am paid an hourly wage for the work I do for them, but you should keep that in mind. Well, Art Sanders and I wrote this editorial for JAMA a number of years ago when Graham Nickel produced his paper showing a 500% difference in outcome depending on where you were in the ROC consortium. And we simply pointed out that it's just like real estate. It's all about location. But what if the location of your cardiac arrest is in the cath lab? On one hand, it would seem that that's a good place. There are lots of staff. They're usually experienced in critical care cardiology. Often, the cause of the cardiac arrest is known, and the opportunity thereby exists to fix the very problem that created the cardiac arrest. But that opportunity is a double-edged sword, because if that patient walked into the cath lab and now is in cardiac arrest, it's because of what I did, and it becomes very personal. Not to minimize the patient-doctor relationship for someone who has an arrest outside the hospital, EMS brings to the emergency room, but this one becomes very personal because of that circumstance. And so there's a need to fix that underlying problem as well as continue to support that patient with systemic circulation. Let me show you a case report. I'm not going to show it all, but this was in the New England Journal just a couple of years ago about a 52-year-old man who had an inferior STEMI, went into cardiac arrest, and was getting CPR in the cath lab itself. So what do you see periodically in that picture? You do see the coronary, the catheter. You saw a right coronary, not quite. And how about this picture? Wedding ring on this side, watch on that side. Pretty easy to identify, in fact, that somebody's hands are in the X-ray beam. And you don't want them to be your hands. Well, indeed, though it would appear initially that a cath lab would be the perfect place for a cardiac arrest, it actually isn't so. First and foremost, it can be quite difficult to perform. Even in large cath lab angiographic suites, there's a limited amount of space. There's a fair amount of materials, particularly the X-ray equipment, that consumes the space at the head of the patient. I'm going to be on the right side, whether I'm working out of the right radial or the right femoral. Guess where I'm going to put you if you're doing the compressions? On the opposite side of the table. And typically, it's quite common that even if you're on that side where there's fewer people, you're literally going to be reaching like this to do your compressions. It's not as simple as being directly over the patient who's on the ground. So there is an ergonomic risk to your back. We've already seen that your hands are at risk. And finally, if you know the cath lab situation, there is the image producer under the table and the image intensifier above. The beam goes through those two with some scatter. But if you're on the left side of the table with your hands in the beam, your head is right next to the image intensifier. And that likewise is not a desirable position and indeed exposes you to really quite high levels of radiation in that position. Well, look carefully at this. I put it in there because in 2010, let me get rid of that. In 2010, we wrote this. Although high-quality compressions improve the chance of resuscitation, it can be difficult to do such during PCI, and we put this picture in to support that. What's wrong with that picture? There's no way I can do PCI while it's in that position. Whereas the X-ray machine is sticking over here. I need it right there if I'm going to be able to work simultaneously while you're trying to provide my systemic circulation for that patient. The answer really does appear to be mechanical CPR. It's been alluded to yesterday that maybe these special circumstances, mechanical CPR still has a role. I think this is one for sure. What are the positives? Well, once you have that device in place, you literally can keep your hands out of the beam, save your back, and continually compress for systemic circulation. There is no fatigue. There's no changing of rescuers. It's really ideal for that. However, there are still challenges. One is the time needed to place the machine and that transition. We've heard already yesterday that that can be anywhere from 13 seconds in the out-of-hospital experience in Anchorage, Alaska with Mike Levy's study, to up to a couple minutes if you're not paying attention and you don't frankly even know where the device is. And finally, there are some limited views because of the hardware of both devices. This is the AutoPulse device, a backboard that's full of electronics with a fabric belt across the chest that is pulled down and across in a rhythmic fashion to compress the chest. And you can see that, again, in an illustration, here is no chest compressions, manual, no chest compressions while the device is being put on, and now the auto pulse with small pauses for ventilation. But once it's on, it actually runs quite well. This is how it looks in the cath lab without the patient. But this is how it looks during angiography. You can imagine, I think you can see the catheter, the wire, and the balloon between these two dots. So in this particular view, a very steep areocranial, you can see it. Here's that same illustration, the balloon inflated. But here's a different view, apicranial, now looking down, and what's it seeing? It's seeing the backboard in the view. Can you see the wire now? It's not this, but it is there. This is the radiolucent tip. It's actually right here. Very tough to see. Here's that exact same view with the autopulse removed. And now I think you can see, if you're looking really carefully, you can see the wire. But with all that other artifact from the metal in the device, very tough to see. Here's the second device, the Lucas, which is actually on display right outside my right hand. Notice, again, actually this is a little more accurate. There is an active PCI ongoing through the femoral right artery with the device in place and with the X-ray equipment in a very steep AP or slightly LAO cranial view. This is a company slide, but it's actually very effective. What did you notice there? The backboard here is specifically designed to be radiolucent. However, there is electronics in the column, and certainly the column gets in your way and will not allow an AP view. But in truth, the most important views for coronary intervention are not strictly AP, but they're very much high cranials, low caudal views, all of which are feasible with this device, as shown here with multiple different examples. Well, let's show you what it looks like as cardiac arrest occurs during angiography. Notice there's not a lot of fill of the coronaries. unfortunately, the aorta fills and stays fills. Why? Because there's no forward blood flow. This is a very bad sign if you're the angiographer, right? Here's what it looks like with Lucas chest compressions. It's not easy, but you can see you can certainly fill, and get rid of that dye. In other words, there's good blood flow being generated. So how do you actually do this? Well, in fact, you can place your wire, even with that motion, pretty readily with ongoing chest compressions by a mechanical device. You can even bring your balloon in. Most people would stop just for a second, make sure their balloon is where they really want it to be, start the compressions again, do their inflations, being able to deflate and remove the balloon the same way with the stent, bring it right up into the proximal piece of vessel, maybe then turn the device off for just a few seconds, place the stent exactly where you want it, turn the device back on, do the compressions. You can inflate the stent while the compressions are going on, and then actually deflate and remove the devices. Well, here's the first series that was available, the last rendition of the guidelines in 2010, just barely published that year, and I'll show you the newest update. But this is 43 patients, all suffered cardiac arrest in the cath lab. 5 had spontaneous rupture associated with their MI. They all died. Of the other 38, we have this kind of flow. 21 still died in the cath lab. 17 were fixed and survived to leave the cath lab. Another 5 died in the hospital, including 2 in cardiac surgery. But bottom line was there were 11, 29% of the 38, or 25% of the 43, who survived and went home neurologically intact. That's not a majority, but it's more than zero. And truly, with manual CPR, it's really close to zero. It's somewhere between 0 and 10%. Well, this is in fact what they just published, updating the series, and now they have 75 patients. They've put them in parallel here. Another 32 patients. Again, 17 of the 32, half expired in the cath lab, but another 25% discharged from hospital neurologically intact. So now 75 patients, 19 survivors, for an overall, it looks like 25%. Appears to be a very realistic number. This I find intriguing. Of those 75, unfortunately a minority are in VF, 11, but of those, as you would expect, pretty good outcome, 55% or 6 of the 11 survived. 14 were in asystole, of which 7 survived. Very obviously not different, 50%. But the majority are in pulseless electrical activity, and they don't survive as well. Only 15 or 14% survived of that group. We really don't know why, but I think it's this, that if your heart is so sick because of what's happened, left main occlusion wasn't timely reopened, that it simply can't even respond to the electrical signal even when it's intact, it's a bad sign that you've really hurt the myocardium. And I think that's translated into much worse results in the long term. Well, the other lessons we've learned, we published in this open access journal a few years ago. And that is simply an effort to share what we have found from this experience. Number one, if they're in ventricular fibrillation, certainly we would try a very quick 1 or 2 defibrillation shocks. If that didn't work, we would move on and use a Lucas or auto pulse to generate flow while we corrected the problem, i.e. the left main occlusion or whatever it was. We would not continue to shock, hoping that suddenly it would now work until we had fixed the problem. And indeed, we'd even wait, we'd open that left main, stent it, and then allow 2 more minutes or so of good circulation with the device, and then defibrillate. And when we have done that, it has been uniformly successful. We would pay close attention to the physiologic parameters we're entitled to in the cath lab, i.e. blood pressure. Here's an example. The device was put on, and this is just a summary trace. Obviously, these are not the waveforms. But when the device first went on, they really want me to go on the internet here. The systolic pressure was not very good, 40 to 50. But first adjustment, well, not really much better. And then we moved the device just slightly and readjusted a second time, and now look, we were getting systolic pressures of 80 or even 90 to 100. That's a big deal. Well, this is the most recent device in the interventional world, the Impella left ventricular assist device, percutaneously placed, and almost no one who's doing high-risk intervention now will do it without this backup. So it's put in ahead of time through a femoral artery, left or right, inserted in the left ventricle, and is a wonderful rotary pump device that takes blood, here's an inlet area, from the left ventricle, and it extrudes the blood in this outlet area, not well seen on this slide, but the aortic valve would be here. So it simply takes it out of the LV and dumps it above the aortic valve. It afterload reduces marvelously. There's this interesting report a few years ago of the Impella as circulatory support during refractory VF in the cath lab. 2 cases, I'm not going to go through them in any detail, but both got chest compressions while the Impella was in place. And so the bottom line really still remains, was it the Impella? Was it really a pump? Or was it the CPR? So we decided to go investigate that in our translational laboratory at the University of Arizona in our pig lab. We put together 3 different groups, manual but dramatically interrupted, because that's the way it truly is. We would do 20 seconds of compressions and then stop for 40 seconds. Then 20 seconds. The only thing we didn't do, I didn't go down and yell at the people, because that's what it's like in the, stop, I got to see the wire. I can't, get your hands out of the way. We left that piece out. Then the second group was assigned to a mechanical chest compressor, Lucas, and the third was assigned to an Impella group without compressions whatsoever. In order to make it realistic, we wanted a model that would cause cardiac arrest in the lab. And so we took these pigs and we put what I call reverse angioplasty, a large balloon, intracoronary balloon, in their left main and blew it up and left it up. We also had a pacemaker in place so we could electrically fibrillate them 1 minute later. They will fibrillate if you leave that left main balloon up, but it adds a variable you can't control. Some fibrillate at 30 seconds, some at a minute and a half. So we ended that by just fibrillating ourselves at 1 minute. Now, in truth, we put the Impella in beforehand as it would be done clinically and had it on as it would be done. These are running at the time, and so then and that's been the thought, that if you get in trouble then, well, the Impella is going to help you. It's going to take over. In the manual arm, we started immediately when we saw VF to do compressions, but in the Lucas arm, we waited 1 more minute as a penalty of the price you pay to put the device on. And we left that left main balloon occlusion for a total of 6 minutes. Then we reopened it as if we had successfully reperfused. 2 more minutes, and then we defibrillated. We looked at ROSC, ICU, and then 24-hour survival with neurologic evaluation, as best you can do in pigs. Well, here's the results of that early work. 10 animals in each group. Dark bar is return to spontaneous circulation. Light bar is good neuro at 24 hours, CPC 1 or 2. You can see, as you would suspect, the manual or almost pseudo-control group did poorly. When you interrupt compressions that much, you neither get the heart back nor the brain. 3 out of 10, 2 out of 10 at 24 hours. The Impella, interestingly, was able to get 8 out of 10 back with return of spontaneous circulation, but the following day, only 4 of those 8 were good neurologically. In other words, it seemed to provide enough flow for resuscitation of the myocardium, but not enough to preserve their neurologic function. Completely unassisted, only as it's pumped. And the Lucas, with continuous chest compressions, once started, again, there was a 2-minute delay there as a penalty, both able to get 9 out of 10 back. That means I should probably stop, I think. 9 out of 10 hearts back, and 8 out of the 9 were neurologically excellent the next day. Well, we have several ideas why this might be. Number one, I think the Impella does exactly what it was designed to do. It empties the LV fabulously, but it simply drops that blood 3 centimeters above your aortic valve. There is nothing to push it from there across the arterial bed, capillary bed, and particularly the lung, and refill your left atrium, hence either your left ventricle. And I assume this is actually very much like tamponade physiology, where the LV is emptied and there's nothing bringing blood back. Hence, there's very little forward flow after a while. Well, in conclusion, that is clearly just pilot work. We've presented that but not yet published it. We have a manuscript in preparation. But that would be an interventionalist dream. If I had a problem like a left main occlusion that resulted in cardiac arrest, if I had that left main reopened and working well in 6 minutes, I'd shout for joy. I'm not sure that's clinically realistic, and so the next phase we're doing is frankly extending both the time of left main occlusion as well as the period of ventricular fibrillation. I think this is a nice example of where mechanical CPR does offer a real advantage. Cardiac arrest in the cath lab. It's safer for sure. It provides the opportunity for continuous chest compressions without somebody yelling at you. And the early clinical results, non-randomized, just before and after or just experience, shows about a 25% long-term neurologically functional survival rate, where today, again, it's probably 5% at best. Thank you so very much. I've had a wonderful time in your city.
Thank you.